Thanks for having me. I want to say right off the top that I know I may have lost half the audience with the title alone, but I promised Cameron and Ruby that actually I'm not going to talk about HCC at all. What I'm going to talk about is sort of a side project, a passion project that I've had for the past 10 years looking at disparities. And so I changed my title slide so that it's really about, I gave them a money back guarantee that this would be relevant to everyone's practice. So, and I also really wanted to, if it's okay, this is an intimate group and we all know each other, and I kind of wanted to just share sort of the more, I don't know, humbling, humorous side of how our careers take us in one direction. You know, we make certain plans, but they go a different way, and a sort of humorous journey of mine through this project. So as many of you know, I did my residency and fellowship here, and then my first faculty job was at NYU, and I was at NYU, but primarily Bellevue for the first 4 years of my career. And it was a great experience. You know, just everything is very dramatic there. The pathologies are very advanced. It was a great place to sort of get my feet under myself as an attending. And I was really naive and optimistic and ambitious, and I said, oh, you know what I'm going to do? I'm going to go get a grant. That's what I'm going to do. I'm going to, you know, I'm going to get something from the NIH, and I'm going to get some funding, and that'll get me some legitimacy. And so I had all these ideas that I was going to do some sort of surgical trial or randomize patients to one thing or the other. And the thing is that I looked around, and what you see when you're at Bellevue is that although there are a lot of patients having surgery, there are even more patients who aren't having surgery because they have advanced disease. And so I toyed with these trials that when I finally narrowed down the inclusion criteria, there wouldn't be enough people in the study really to get attention enough to get funding. And I kind of said, well, what do we have in abundance? And what we had in abundance was disparities. And so that's kind of how a surgeon ended up doing disparities research, which is pretty unusual, I can tell you. So this is really a story about my journey through disparities research and what I've been sort of doing with that now for really almost the past 10 years. So that's what I'm going to propose. And it's not news to anybody that there are disparities in cancer in general, and of course it's true in HCC too. This is just one example of an article showing that people based on race, ethnicity, and socioeconomic status have worse outcomes in HCC. But that's old news, right? We all, you know, the fact that disparities exist is very 1980s and 90s. We knew that. And really what the way the field has matured is to go from just talking about the fact that there's a problem to understanding the underlying mechanisms and then trying to come up with interventions that you can do. And so I was looking at liver cancer specifically, partly because Bellevue has a very large Chinese population, which is obviously a group that has a lot of HCC. And so I said, well, you know, how hard can this be? Let's really hone in on this population. Let's track them from start to finish. Let's find out why they're not getting, you know, their resections or their transplants, and let's see if we can find an intervention that's effective. But what I soon found out, you know, I found mentors and such, but it was, you know, definitely a learning process for me, is that obviously disparities are multifactorial, and it's very hard actually to nail down where the problem is. I mean, we talk about race and ethnicity is an easy one to point fingers at, but how often is it really about race or ethnicity? It's often about, you know, the underlying language disparity or a cultural difference, or maybe a socioeconomic status that minority faces at a greater rate. It could be issues with the community, it could be the physicians. As one of my mentors told me, discrimination and disparity are not the same thing. They're different things, and so it could also be a physician factor. Could there be discrimination at play? And so there's all these different things to look at, and I said, okay, well, we can't look at all of them, but what could be something that's driving the disparity in liver cancer? And one of the things that I noticed, having trained at Sinai, was that there didn't seem to be a ton of transplants going on for HCC. There is a transplant center there. They do a lot of transplantation, but very few of my Bellevue patients were getting over into the NYU transplant program. And so one of the things I thought was, well, let's just really hone in on transplantation rates because, you know, just all comers, those who receive transplantations do better. And so I thought if there's a disparity in the best treatment, then that's it. I've found the mechanism, and all we need to do is get people more transplants. I mean, I'm being light about this, but in I guess that's in my, again, naivete, how I saw things at the time. And so, and here are several articles that confirmed, in fact, that minorities receive transplantations less for HCC specifically. So I was saying, okay, this is great, but these articles weren't very good. They were problematic in that they didn't really rigorously match for eligibility for transplantation. They didn't look at, many of them did not look at underlying liver function. And so I said, okay, this is what we're going to do. We're going to start with some very hardcore data crunching at a tertiary care center. We're going to really look at transplantation rates, but we're also going to take this deeper. We're going to go into the neighborhoods, talk to the PMDs who are actually, seeing and diagnosing these patients with HCC. And then we're going to go down even deeper. We're going to reach into the patient population themselves and do interviews, do focus groups with the patients, and we're going to figure out a mechanism, and it's going to be actionable. And then my next grant's going to be the intervention study, and so it'll be brilliant. Much to my surprise, after one addendum, I actually got an R03 from the NCI, which is beginner's luck, but was very exciting. It was about $200,000, and literally the same week that I found out that my study had been funded, and I'll tell you more about what it actually was, I actually signed a contract to come back to Sinai. And so there was like this sort of moment where I said, oh, this is great, until someone told me that, and this is a little known fact, that when you get a grant, actually you're not getting the grant, your institution gets the grant. And so there was like a few days of panic where I had just gotten this NCI grant and had signed to change institutions and was leaving the grant behind. And I have to say that NYU very generously signed off and let the grant come with me to Sinai, which they didn't have to do. But so then I came to Sinai and I was all excited again, and I said, okay. And I went to the liver DFG and I said, guys, I'm so excited to be back, and I have this grant and we're gonna look at disparities, and it's the same thing. We're gonna, look at it'll be even better because we have a bigger transplant population here. And so we'll look at the transplant numbers and then we're gonna do the whole thing. And I was a little bummed. A prominent person said, but we don't have disparities at Sinai. It's like the quote. And I was upset because I was sure that there were disparities, but I knew what they meant. I knew that we think of Bellevue, we think of something very sort of dramatic, and then we think of Sinai, and I know we'd like to think that we don't, but so it sort of almost put a chip on my shoulder, where the first part of what I had to do was kind of prove what I thought we already knew. So I'm going to kind of walk you through these three different levels that this grant took me through. And the first part was the Tertiary Care Center of Sinai, looking at very raw sort of data, very rigorously controlling and trying to confirm whether this disparity in fact does exist here. And so what we did was we took everybody with a diagnosis of HCC and we walked them through the steps that you have to go through, right? Because you don't just get a transplant, you have to go through these very discrete steps. You need to go see a specialist first, be that a surgical oncologist or a transplant surgeon. You may get a transplant, you may get a resection, assuming that you're a candidate for these. If you do go the transplant route, you need to get listed with UNOS, and then you need to actually get through the wait list and get a transplant. And so what we said was, okay, we're going to actually track people through each of these stages. I'm going to find where the fall off occurs. Where is the disparity actually happening at which step? And then that was the step that we could focus on, and et cetera. So that's what we started to do. So this one slide probably took me like 2 years because it was, as you all know, just identifying your cases, cleaning them, making sure they're real. But ultimately what we found was about 3,000 cases of HCC here at Sinai over the past 10 years. And I worked with, I have an acknowledgement slide at the end, but obviously I worked very closely with the transplant team here to help identify really who would be considered an ideal candidate, because there's no point in talking about disparities among people who were never transplant candidates for medical reasons, right? Because you can have differences in your eligibility for race, ethnicity, socioeconomic status, et cetera, reasons, and I really wanted to make it as clean of a comparison as possible. So we somewhat arbitrarily took out people who were greater than 70, just saying they have a higher chance of not being a candidate. So then we came down to about 2000 and some, there were a bunch of patients who had medical contraindications to transplantation, like pulmonary hypertension or things like that. And then we kicked out those people who were not within the Milan criteria. And then of those who were transplant eligible, a bunch of them had resections and so didn't need a transplant. And so what we ended up with was about 750 patients who everyone agreed that their HCC, that they were transplant eligible, that they ought to have been considered for a transplant. And of those, 289 actually got a liver transplant. And so this, at the end of the day, was the group I really wanted to look at and see in that group, did everyone get a transplant evenly, or were there differences in that group? So what we found was that there were disparities at Sinai. And there were disparities based on race, significantly, and also on insurance status, so commercial insurance versus government insurance, or even government with a supplement. And so, okay, that we knew, but we confirmed it. But then what we did, and it's a little bit of a complex slide, but these are the same steps that I talked about before. So if this is time moving forward, this is your diagnosis, your special visit, your transplant eval, and the top arrow is the whole group of 750 patients moving through in time each of these steps. And as I mentioned, there's the 750 that we said merited a transplant eval. And then in between each step is the drop off that you had. And so that ultimately 289 got the transplant. And there were differences, as I mentioned, in insurance and in race. And what I was looking for was this dominant hurdle, like where did all the fallout occur? And really, unfortunately, although the fallout was happening at greater rates progressively throughout, there was no dominant hurdle. And I think maybe those of us who are a little bit more jaded in the room kind of could have told me that. You know, there isn't one point where people just fall off. And if you just focus on that one spot, you can, save the world. And in fact, it just turns out that people just trickle off these lists. And so then I said, okay, well, so there's no dominant hurdle. Let's look at the patients who weren't listed. Like, let's look at the reasons why they weren't even listed. If we look at one of those fallout points, and could we figure out what's different about them and why they aren't getting them? And we've divided the group into sort of clinical reasons why they weren't getting listed and social reasons. The clinical reasons, you kind of can't help. Well, that's actually another discussion. I mean, these are patients with prohibitive comorbidities. Could there be disparities in why you have those comorbidities? Sure. But for now, what I wanted to focus on were the social reasons. Things like active substance abuse, right? If you have that, you can't get listed for transplant. If you have inconsistent follow-up, or if you have a failure of a psychological screening, you're not going to get listed for transplant. Was there a lack of financial clearance in this group? Patient refusal, maybe due to cultural factors. So we looked at these social reasons, and in fact, we did find that there was a statistically significant higher rate of social reasons for not being listed in the non-white group and in government insured individuals. And so it implied that there was a whole component to the social reasons for not getting listed that was different. How do you action on that? I don't know. It's a very complicated thing, but it was, I thought, at least useful to acknowledge that that was a big reason why these people were not getting listed. They also had a higher delay in diagnosis, so it took them more than 3 months to get to the specialist. So that was also part of it, is that a lot of these patients were just not getting in front of the right people. So we ended up publishing this article, basically describing that. But then, like I said, we wanted to kind of keep going and take it through to the next level. So then the next part of what we did was we went into the neighborhoods where there were the highest rates of individuals who are at risk for HCC. And so based on the idea that we were seeing that HCC was getting diagnosed in later stages, that screening rates are already known to be very low in minorities, there are guidelines out there, but maybe people weren't following them. How can we get these people in sooner? And we wanted to also, as an aside, compare similar communities. We know that the HCC rate's high in the Chinese community, but also in the African community because of the endemic rates of Hep B and aflatoxin. And so we did this related study where we used the census to identify the 25 neighborhoods in New York City that had the highest rates of individuals born in China or Africa. And so we came up with this map. And this was another thing where I think it makes for a nice slide, but this one slide took like a year to put together because it's actually really hard, as it turns out, to get the government to give you census data, to map it all out. But ultimately what we found was, if you look at these sort of gradations of red, this is where the Chinese population lives in New York. Some of these areas are obviously recognizable as Chinatown and Flushing, Brooklyn and Queens. And then we also looked at the African-born population, and they're clustered somewhat in Staten Island, obviously in northern Manhattan and the Bronx. And so then what we did was we used the American Medical Association's database to identify primary care doctors who were living in these, who were practicing, whose practices were in these zip codes. And we surveyed them about how they treated HCC, or even before, how they screen people with Hep B. How these are physicians who are seeing the highest risk patients. Are they getting Hep B on their immigrant patients? If the Hep B is positive, are they then getting ultrasounds or enrolling them in HCC screening programs? So this is just a demonstration of the fact that the Chinese population is much more densely clustered in a fewer areas, whereas the African population is more spread out in those zip codes. So it's not quite as cohesive of a group. But so we sent out surveys to these physicians, and we asked about the things I just mentioned, like we tested their knowledge, like if you have Hep B, is it possible that they can get liver cancer even without cirrhosis? And most people knew that that was true. We talked about whether antiviral therapy for Hep B can prevent liver cancer, and most people got that, although less. We talked about what the screening for liver cancer was, and then we talked about some areas where people really, it was a wash whether they knew. The screening actually improve your outcome. It does, it's been shown, but only about half the practitioners knew that to be true. And is it possible that should a 25-year-old immigrant from Africa who has Hep B positive be screened for liver cancer? And the most recent AASLD guidelines say that early screening starts at 20 in this population, and so even that was really only 50-50 true. So sorry, I went too fast there. And so then we asked, okay, even in those patients that you want to screen, why aren't you able to screen? What are the reasons? And what we were shocked to find was that they felt there were lack of clear guidelines on screening, which for those of us who practice, in this like academic center, that's all we do is, I feel like, memorize these guidelines, and then every couple of years the guidelines get updated and we memorize those ones. And so I think, if anything, there are very clear guidelines. And yes, other things were true too, like competing healthcare priorities and time constraints, but people felt the guidelines were vague. And so we were surprised to hear that, but that was actually something that we thought was potentially actionable. Interestingly, we also asked doctors what their patients were most concerned about when they came in to see them. And hepatitis B and liver cancer were not even in the top 3, which is also interesting. And again, you're getting the idea of how, this is progressing through time, and you're sort of realizing there is no one actionable step. It's just, it's so pervasive how these disparities affect people. So not only are we seeing that patients are unaware of their risk, the doctors that they're seeing in their communities are unaware of the best ways to screen them for these risks. And then they have all these other factors in going around in their lives and in their communities that are affecting whether or not they, even when they get into these sort of rigorous tertiary care center places, that affect whether they're getting the best treatment for HCC. So it was getting more and more depressing in a sense. And then the grant, and I think this actually may have been why this study was funded, because part of the grant included going and talking to patients. And I think that was something that was not novel, but appealing. So to the NCI, and what we did was we put together focus groups among patients, and we decided to focus on the Mandarin-speaking Chinese immigrant population in New York, just because that was where we knew we had the highest group of patients. And so we put together these focus groups with these patients, and we said, okay, well, we'll ask patients, rather than talking about patients and just crunching them through our models and in a way being sort of paternalistic about it, like, we're going to go to the source and we're going to say, well, what do you think about liver cancer, and what are the barriers that you feel when going through the system? We can assign what we think is happening to you, but maybe you'll, be able to tell us what are your actually experienced barriers to care. So we put together these patient focus groups, and we had about, I think about 12 focus groups that we ran. We did 8 that, and then had another 2 that were just in patients who actually received, so it was 10 total actually, that received transplants, because we figured that 8 was sort of more like a general, represented the general community's knowledge. And then we had these patients who were uber experienced, had really been through the whole process, had been on the list, who'd actually gotten transplants, and we thought their experiences would be so different that we separated them out. And so these were patients, all of whom were immigrant patients, primarily Mandarin speaking, meaning they were English was not their first language. And we had hour-and-a-half long focus groups with a trained Chinese facilitator. For this part of the project, I teamed up with MSK because they have a very well-established disparities group there, and they have a team that does these focus groups, and they have focus group facilitators and the whole 9 yards, which we don't have or didn't have at the time at Sinai. And so we spoke to these patients and we talked to them about their knowledge, their level of their knowledge about Hep B and HCC, their access to treatment, the decision making around their care. Like how did they come to their decisions? Their attitudes towards traditional Chinese medicine, the presence of their social support networks, all things that go into how you go through your experience in having a disease. And this was also very labor intensive. I feel like I'm complaining this whole talk, but it was, you have all these ideas and you write this grant and you think, oh, I'm going to get this done in 2 years. It'll be great. I'll have an answer. And then that'll launch me into my R01. And in fact, it wasn't. So what involved was the focus groups were run in Mandarin. They get transcribed in Mandarin. Then they need to get translated. And then they actually get, as it turns out, the most rigorous way to do this is to translate it back into Mandarin and then have a Mandarin speaker read that back translated model and confirm that it is still accurate. That's how they do the quality assessment. So, 10 focus groups, an hour and a half long each, had to be translated and back translated and verified. I mean, it was very rigorous. And then once that the back translation is verified, it gets put out into a transcript, and there's this program called Atlas TI that I had to learn about, and you go through and you have various readers that read all of these transcripts multiple times, and I learned all about qualitative analysis, and basically what it is that you just keep reading these transcripts over and over again until themes emerge, and you code these various themes, and then you get together with the other people who have been reading them and you talk about if everybody's coming up with these same themes, and essentially you reach what's called saturation, where you come up with pretty mutually agreed upon themes that are being talked about, and that no matter how many more times you read it, you're not going to get any more themes to come out. You've saturated the discussion. And so when we went through this, we ended up with several themes. And here's just an example of some of the codes that we were working on. And then a lot of these fall out. They turn out not to be consistent between people and stuff. And then we ended up with several sort of key areas. And I just wanted to spend maybe the next 10 minutes or so just taking you through what patients said they felt were their barriers to getting care, because I feel like maybe this is something a bit different that we don't hear about in a lot of the kind of talks that we listen to. So these are what patients say about their experience. One major theme, not surprising to anyone, was that insurance was a major issue. And so, in fact, lack of insurance was described as the single largest barrier to care. People said it was the biggest problem. They won't see you without insurance. So for people with our disease, insurance is the most important thing. People talked a lot about the cash out-of-pocket price of various blood tests, exams, medications. If you don't have insurance, one scan is a couple $1,000s. Someone said that my type of medication, they cost about $1,000. Without health insurance, I simply couldn't take them. Without a health insurance, liver cancer will cost you a lot. People talked about having to ration their medications, that they actually sometimes would reduce the dose, that they would take less of it. A widespread theme throughout the focus groups was not just being insured or not, it was about the quality of your insurance, which for me was, it went back and it linked up with what we found was that Medicare and Medicaid patients had statistically significant worse transplantation rates even when rigorously matched. And what they talked about was, it's so miserable. Us low-income people, our insurance is rotten. Most of us have government insurance. It doesn't give you the good medicine. It gives you the regular medicine. And I think a lot of people are probably talking about sorafenib or some of these newer antiviral agents that were covered or only partially, that were not covered or only partially covered. Despite these frustrations, though, it was, it's not black and white. Patients also had positive things to say about the social welfare system in the U.S. And emergency Medicaid, which is something that I learned about when I was at Bellevue, which is that for all the debates that happen on TV, even if you're an undocumented resident, you can get medical care, and the same medical care, actually. At Bellevue, you will be, you can have surgery, you can have chemotherapy, you can have any level really of treatment, regardless of your immigration status. And so
emergency Medicaid, I think, is state by state. We are lucky.
We're lucky. That's right.
New York will cover emergency Medicaid, but there's many states that don't have emergency Medicaid. And I know the colon cancer screening literature, there are many states that don't want you to do screening colonoscopies because if you find cancer, they don't want to have to pay for it.
Yeah, I think in Arizona a few years ago, right, there was an article about that, and people were, essentially dying of treatable diseases.
Right, because the state doesn't want to pay for the $30,000 surgery
right.
if you find cancer.
That's right. So people were grateful for that, and they expressed that. Even if you can't get insurance, say if you were undocumented, they'll still get you a temporary one. Social Security handles this. I didn't know the laws, but once I was there, I was hospitalized. They gave me a temporary insurance. I was able to live on. I didn't spend a penny. At first, I had no idea. I thought it would cost a lot of money, but they took care of everything. Money was a separate issue. And at first, we thought, okay, it's the same thing as insurance, but it really was distinct. They talked about the copays, that copays were things that essentially made something untenable for them because copays add up. So they say, to do stuff, it costs $200, but $200, and as far as we're concerned, it's a week's worth of wages already gone. And so you can be insured, but still unable to receive treatment. I had to put out a few $100s every month. The wages from work, these burdens just become too big. As long as they can endure it, they'll endure it. But at a certain point, you just can't anymore. You can't keep up with it. When it comes down to it, I couldn't deal with paying that money, so I just stopped taking the medication. And again, these are patients who were insured. Specific also money that's distinct from insurance was that people talked about the fact that it's a vicious cycle because if you're sick, you can't work. If you can't work, you can't make money. And so they talked about the fact that they're not able to work as much. People talked about having to rely on family members. And people also expressed a feeling that they felt that it was harder in a foreign country to get by, that they had fewer people that they could rely on. So one person used this anecdote. In America, if you have no money, it's hard to get by even an inch. In mainland China, for example, I could still borrow your bicycle as an expression. But in America, people found they couldn't. In America, you have to depend on yourself. You're pitiful. If you're starving to death at home, it's your own problem. And so people really talked about the lack of support that they felt. Time was an interesting barrier which came up that I wasn't expecting, but people talked a lot, and this hadn't occurred to me, that the luxury of time to take care of yourself is something that not everybody has, especially in immigrant populations. And so people talked about the fact that they couldn't take time off work. When one patient said that he was giving advice saying, you need to reject any work that you may have on the day of your appointment. You don't make that one day's money, but you still have to go forward with your doctor's appointments. But it's true, you're giving up on the wages for that day. If you were to tell me to skip a day, I would lose my job. I wouldn't give up the job in order to get my health examined. But now that I know I have this kind of disease, I would have gotten my health examined the first time around. I would go find another job. This is the most important thing. Also, in terms of time, people talked about the fact that it wasn't just your time. You had to also get family members to take care of your kids or your elders. And so these issues clearly interfered with care. But I didn't have the ultrasound. The doctor requested that I go get it, but I didn't do it. There's every kind of reason. There's work-related reasons, time-related reasons. There are many aspects. People talked about having to wait for hours in the waiting room, and it's true. At Bellevue, it's a clinic situation, and every chair in the waiting room would be full, and it would take us 3-4 hours to get through the morning clinic, and people waited. The wait time is too long. You generally need half a day. Once I came at 11 o'clock, by the time I finished seeing the doctor, it was already 4 o'clock. And again, these are patients who don't have the luxury of taking time off work. Some participants who were retired actually commented on that. Because we're retired, although we need to wait for a long time, you have to wait your 3 or 4 hours, it doesn't matter. And that was interesting. It never occurred to me that where you are in your retirement can affect how well you can pursue your health care. And another described how those with private insurance definitely experience shorter wait time. So people notice, right, that there's a difference here. If you want it to be fast, going to see the doctor, it'll take more than $100. Who has that kind of money to see the doctor? We're retired. We only have $400, $500 per month of retirement income, so we'd rather be here and just wait. People also, another aspect of time that was fascinating to me was scheduling appointments. We don't think about it, or I didn't think about the fact that all the times that we have to schedule our appointments are during work hours. And so if you have a job that, again, you don't have the luxury of taking time off, how are you supposed to, even if you're being seen on time, meaning even if you're not kept waiting, you can't make a 2 p.m. appointment. And so there's the money problem on the one hand, and although it's a big problem, there's also the issue of time, the time they spend working those times in Chinese restaurants. The tests have to be compatible with their work hours, and they need to work. If the time isn't compatible, they don't have any alternative. When they go, the clinic is already closed. Additionally, many participants stated that they lived in outer boroughs requiring long commute times to Manhattan hospitals, and they were simply unwilling to spend their one day off at the doctor's office. There are obstacles in making appointments, and the most crucial point is how to put it. Chinese people, some work in restaurants, sometimes in an outside state, not necessarily in New York, and they only rest 1 day per week. Some of you may be familiar with the phenomena where a lot of Chinese immigrants, especially those with limited English, are actually bussed out to neighboring states where they work through the week, and then they come back and they only basically have a day at home with their family, and then they get bussed out again. And there's a whole network. It's described in, I think, The Snakehead is one book that talks about this in popular culture. But and it's true, they're not going to spend that one day coming in and seeing the doctor. Language barriers. This one was obviously no surprise. We're all familiar with language barriers. Not understanding English, you're just like a blind person. And then I loved this quote. It doesn't depend on the doctor, it depends on the interpreter, right? Because it's true. At the end of the day, we think we have all this wise stuff we're going to tell the patients, or we're going to figure out what their diagnosis is, but it's the interpreter that's getting that information from them to us and us to them. And if your interpreter is not very good, what can you do? And although, yes, the law requires telephone translation services, and at Bellevue, every single room, some of these focus groups were at Bellevue, and some of them were here because I kept that tie and I wanted to include some of those patients. So just like there is here, there were phone services available there. There were many preferred to bring a friend, which is a whole other person who has to take time off work. So these matters got compounded. People talked about the fact that sometimes the translators didn't have the medical jargon down. And so people, again, preferred to bring friends or family members. But then people also did say positive things. They talked about the fact that now they can help you in Cantonese and even in Fujianese. And so people were appreciative, but there was clearly still some barrier to language. Here's what I was saying before. They don't know some of the specialized terms. We can handle simple conversations, but when it comes to difficult medical knowledge, then we may not understand. And then if asked if satisfied, one patient said, well, satisfied, it's fine because you don't have any other options. What are you supposed to do? And then one area of barriers that I thought was interesting was residency status. And even though I described through emergency Medicaid how I thought that wouldn't be a barrier, it is actually a very hard stop in terms of transplantation. Because one thing that emergency Medicaid specifically, and I actually pulled the code, like the actual law, and there is a line item there that specifically excludes transplantation from emergency Medicaid. And so you cannot get a liver transplant if you have emergency Medicaid, which is what you'd have if you were an undocumented resident. And so this actually kind of was like one of the aha moments where I realized that if you are of a group that is a minority that has higher rates of being undocumented, and that same group, if the Venn diagram of that overlaps with being a group that needs transplantation the most because it's the most efficacious treatment for the disease that's more common in your community, and if you are specifically excluded from that best treatment modality because of something that's more common in your community, that right there was one very specific mechanism that we actually did identify. Not that I know how to fix it, but it was one thing that came out. So they explained that lack of documentation created a barrier to healthcare by virtue of precluding insurance coverage. It's that most Fuzhou people don't have any documentation. They don't have any health insurance. A lot of people are undocumented. They have no way of paying. But specifically, you have to provide. Oh, sorry, hold on, I jumped ahead. This is the slide where I was talking about prohibiting organ transplantation. Although undocumented individuals can receive most medical care via emergency Medicaid, this coverage specifically excludes transplantation. And one person actually said, when I finally got citizenship, they gave me a liver transplant. And then residency status in general was just talking about the difficulties in getting seen at a place like Bellevue. They talked about that you can get care, but it's not like you can just walk in and say, I'm here, give me my emergency Medicaid. One person described you have to provide two types of identification materials, one proof of address and one proof of income. But the proof of address, a lot of these individuals, they don't have a mortgage, they don't have a lease, they're living very unofficially with family and friends in apartments, and so they have no ability to prove, they have no ability to even show the documentation to get emergency Medicaid. And so although it is true that we're lucky in New York, it's still a very difficult thing. And then one of the other things that a lot of these things are external, like what happens to you, but we found that there was also a lot of internal stigma within the Chinese immigrant community. Many focus group participants described significant stigma against liver diseases from within their community. They described it as a taboo topic. Some of my friends are very conservative. They don't want to talk about it. A lot of people don't want others to know that they've had a liver transplant or that they're sick. I have a friend, because when I was on the wait list, I was asking around, and then there was this friend's husband. He didn't want other people to know, so he didn't go out much. I asked him about it because we were friends, but he didn't say anything to others. Some people are like that. They felt that the stigma represented fear of getting the infection. They're afraid, it's not really discrimination, they're afraid of getting the infection. There are those, such as older sisters and relatives, wherever you go, you take chopsticks bowls and immediately wash them, washing to disinfect them. If you sit in a spot, they'll wipe it. Haha. They don't actually understand that if you have a liver disease, that it doesn't get transmitted that way, but they won't shake your hand, they won't come close to you, they're scared of your disease. There's one person who was asked to wait outside when they found out that he had a liver disease. And so there's definitely, within their own community, issues with stigmatization. One thing that I was happy to find was that, as I mentioned at the beginning, disparities don't mean that there's discrimination there. And while I'm sure that discrimination exists, I'm not that naive. What was interesting was that patients didn't experience it as a barrier. So they said, yes, there's definitely some discrimination, a little bit. But people complain more about the other barriers to care than being discriminated against. People said, for example, they don't separate Chinese from non-Chinese. They see us equally. I like this one comment. This I haven't experienced. I haven't felt this at all. On the contrary, I felt that although I don't have any money, seeing the doctors here, as long as I ask the questions I want to ask on any given day, the doctor will answer them. Their sense of medical ethics is beyond words. I mean, obviously, this was someone who was having probably a good outcome and felt grateful, but people commented that American doctors are not like that. And when it comes to equal treatment, America is doing a wonderful job. I didn't feel this way either. I should say that American hospitals are doing great in this area. So for sure, while there is discrimination, people actually didn't feel that that was what was stopping them from getting care. It was all these other issues. And then the last issue that we looked at was culture, because I think a lot of people told me when this project started was that, oh, what you're going to find is that a lot of Chinese patients don't want a transplant. They don't want surgery. They don't want Western medicine, and it's a self-selection out. And if they are, maybe people didn't mean it this, harshly, but it's kind of in a sense their own fault for not getting the best, medical care. And so we looked at culture. We asked specifically about whether cultural factors impacted their healthcare choices. And it's true, there were cultural factors involved that people talked to us about. People talked about a bit of sense of fatalism. After being diagnosed, I've always felt that live or die, it's fate. Another used a Chinese proverb and said, if it's my time to go, it's my time to go. If the heavens want you to die, then you'll die. And while people were fatalistic, that did not translate into them not receiving treatment. They just felt that whatever was going to happen was going to happen. They still went through the process. They did specifically talk about, in general, that in Chinese culture, people try to avoid surgery. I don't think that's that different. But they did say the Chinese try to avoid surgeries. Humans have innate qi. If you cut a person open, you're letting that qi out. And surgeries will let out the qi. And so there was, someone else responded, this gentleman has a point that in surgery you will hurt your qi, and this is true, you can't deny it. But then one person very specifically said, can you, if possible, not operate? Chinese people are scared of surgeries. It'd be ideal if you don't need to operate, but then the doctor said you have to have the surgery, and so I could only listen to the doctor, right? So again, although there were these cultural factors, I think it really took it too far to say that people would go. We found that ultimately people were deferential to their physicians, and they did follow what was recommended. Again, they generally voiced respect for their American physicians, and they would generally follow through with their decisions. When asked about liver transplantation specifically, would they not have a transplant if that's what was recommended? And people responded, no, this is the same everywhere. To prolong life, right? Nobody's going to say, I'm not going to get a transplant because of my culture. There's no such cases, no such cases. There are many people getting liver transplants in China too, I know. There are no cultural considerations like that. That doesn't exist. This has nothing to do with culture. This is definitely linked to medical. Liver transplant prolongs your life. What else is there? It has nothing to do with culture. So in a way, we found it was almost paternalistic and like kind of patronizing that people said this. And again, I thought this was something useful that came out of this was you can't really talk about people and what their barriers are. You have to ask what barriers they're actually experiencing. And so that was interesting to hear. We specifically asked about traditional Chinese medicine, and people talked about the fact that TCM is a very good supportive modality, but people were very open about the fact that it's good to support liver health, but once you have cancer, you need Western medicine, in quotes, Western medicine. And people talked about the fact that they were complementary instead of being alternative. So the money's gone, the grant is over, and what are the conclusions? And it took 3 times as long. I feel like a bad government worker, right? It took 3 times as long. Actually, I didn't take twice as much money because I only had so much money. But what conclusions did we draw from this? Well, I think that we did demonstrate that minorities and government-insured patients receive liver transplantations less often. We knew that, but this time I feel like we proved it really rigorously, because that's even when they're matched by tumor stage, and even when we rigorously controlled for transplant eligibility, even when a transplant surgeon controlled for who would receive a transplant, there were still disparities present, even at Sinai. And we've shown that PMDs in New York City, in immigrant-rich neighborhoods in New York City, are often not familiar with the published screening guidelines, so that's maybe another actionable area. That we've got to get these guidelines out to the communities that actually serve patients in these neighborhoods. We knew and we demonstrated that patients in these areas don't recognize their risk of HCC. And we identified actually experienced barriers to care, which were insurance, money, time, language, residency status, and stigma in the community. And I don't know which of one of these things that we could pick to action on, but it certainly was for me a humbling experience through disparities, and thank you for letting me share it.